nearly afternoon now, so we are running late. And may I request Dr. Dinesh Kini to please come on the dais. And the session would be on probiotics, role in chronic diseases and metabolic disorders. A few words on Dr. Kini. He is HOD and consultant gastroenterologist, hepatologist and endoscopist at Manipal Hospital, Bengaluru. He has received gold medal for best outstanding MD in general medicine and post-graduation. Dr. Kini, the speakers, if you would call them and introduce them.
Yeah, the next session we start with probiotics in cancer. For this we have Dr. K. M. Mohandas, who's the director for, previous director for Center Cancer Epidemiology at Tata Memorial Hospital, Mumbai, and presently he is at Calcutta. And may I invite Dr. K. M. Mohandas to the dais, please. Dr. K. M. Mohandas is presently the Senior Consultant Digestive Diseases at Tata Medical Center, Calcutta, and he has more than 337 publications in peer-reviewed journals. And we start this session with this talk.
Where do I show it? Okay. Good morning, or almost good afternoon, friends, and without much, there has been a lot of discussion about probiotics, and I will get on with the topic that I have been assigned. I bring greetings from my new hospital, the Tata Medical Center, which is a state-of-the-art standalone cancer center in Kolkata. The objective of my presentation is to give you some understanding about cancer in India, the possible mechanisms, how probiotics may affect the cancer incidence or cancer treatments, and the indications where it can be used based on current evidence, and also most importantly, because there is very little Indian evidence, the gaps in the knowledge. The good news is that cancer in India is about a fourth of what it is in the developed countries. Like you can see in the US, Canada, Western Europe, Australia, Korea even, it's all in red, 400 per 100,000 population. India is green, it is about 100 per 100,000 population. And the million death study, which we were a part of this study, looking at a million households in India. The first paper in NEJM and subsequent papers in Lancet showed that cancer was the sixth leading cause of death amongst adults in India. So we still have a number of other health priorities. And if you look at the daily, that is the disability adjusted life years lost, which includes death as well as inability to function, about 4% of India's daily is due to cancer. So one would think that it is not a very big amount in terms of health burden. What is really interesting is there is a huge difference in cancers, particularly that of the GI tract cancers, between India, China, and the West. And even if you look at a population living in a very close community like Singapore, you can see between the Chinese, the Malays, and the Indians, there's a big difference in the cancer burden, particularly the GI cancers. So you can see India has almost half of the incidence, both in men and women, as compared to the Chinese living in Singapore. But the reality is that, though we talk of 4% of daily, so it doesn't look much when you compare it with other diseases, we have 1 million cases of new cancer patients every year. We are, after all, 1.3 billion people, and even 100 per 100,000 makes a huge burden. And out of the 60% are dead at the end of 1 year. So the real problem of cancer is huge. And I would want to take you back to what was happening in Japan around the 1950s using these graphs. And you can see that, problems like tuberculosis, infections were very high, and cancer was about, much less than 100 per 100,000 in the 1950s. And today what's happened, they have no tuberculosis, and cancer is up the 300 per 100,000. So this is what is happening with the epidemiological transition, and I think we are in that phase, and with time, we will overcome some of these infectious diseases and have many more, the NCDs, particularly cancer. And why so? It's already obvious. If you look at cancer rates, population-based cancer rates in rural India, urban India, and Indian immigrants abroad, you can see there's a huge increase in cancer amongst Indians living abroad, and then next in the cities, and least in the rural India. So we are going the same way. What is even more interesting is between Indian states, there is a huge difference. So you can see here northeastern states, Kerala and some of the others, there is much more cancer than UP, Bihar and Rajasthan and Madhya Pradesh. So within India there are variations. Even more interesting is within specific cancer sites there are big variations. So we have huge cancer burdens in South India of the stomach cancer, whereas the gallbladder cancer is much more in North India, particularly along the rivers. So it is obvious that there are a number of different reasons why these differences are there between states, between cancer sites, and some of it, I'm sure, would be because of the microbiota, which we are now discovering. I am actually relatively new to the area of probiotic research, and so I thought I will just do a search. And first thing I found is that there are a huge number of companies that are into the probiotic business, which means it does seem to be an important area. More than $16 billion investment happening now. Then other thing I did was to do a systematic review of PubMed with probiotic and cancer. So you can see that there are about 15,000 studies. Then when you come down to narrow it down, randomized trials related to probiotics and cancer, it comes to about 64 studies. So there are some studies which give you good evidence, because after all randomized trials give you the best evidence. And that's what I'm going to emphasize in my brief presentation. Probiotics and cancer. The kind of studies that are available include laboratory studies, animal studies, ecological studies, case control cohort, and randomized trials with their meta-analysis. And there are very few economic studies, because those are equally important for a country like ours, where the health spending is very little and there is a lot of out-of-pocket expenditure for the patients. I think we've heard a lot about the gut microbiota, how it varies between the upper and the lower GI tract, how it varies with the life span, and where the bacteria reside in the mucosa, in the lumen, in the crypts. But what some of you may not realize is that cancer is a very long, drawn-out process. Even for a disease like adenomatous polyposis coli, where the patient is born with a mutated APC gene and is 100% sure to develop a colorectal cancer, it takes about 40 years for that child born with a mutated gene to develop colorectal cancer. In other words, it's a long process, a lot of events happening, and it becomes extremely important for us to think at what point in this long course will the probiotics work. Do you give it for a short time? Do you need to give it for 4 decades? At what time you start? Because does it affect all the process, I think there is a huge gap. And this is something that we all need to realize before we push further in this research. So there are a number of mechanisms by which probiotics would interfere with the carcinogenesis process. These have been described, and I will skip that slide. But the most important thing is to realize that a lot of cancer is triggered by inflammation that pushes cells to replicate and cause mutations in the controlling genes. So inflammation is one of the hallmarks of cancer, both in terms of triggering the cancer as well as when the cancer has come in, there is a lot of inflammation around in the interstitial tissues, which again contribute towards the cachexia that these patients develop. So if we are able to control inflammation, we are able to reduce cancer, and this can be achieved in many ways. For example, inflammation of the cervix caused by papillomavirus, you can prevent it by giving a vaccine, or similarly inflammation of the liver caused by hepatitis B, you can prevent it by giving a vaccine. You can treat patients who have already existing inflammation in the stomach, for example, Helicobacter pylori, eradicate Helicobacter pylori, reduce the inflammation, and again reduce cancer. So, if we have to assume that this dysbiosis is producing inflammation, which is pro-carcinogenic, then the use of probiotics would restore this imbalance and bring down the incidence of cancer. And that is typically what is shown in this cartoon, that what we are trying to do in theory is that use probiotics to restore the balance and reduce inflammation and reduce the incidence of cancer. So probiotics can have many benefits, particularly local benefits. It has antimicrobial activity, it enhances the barrier functions, and it can modulate the immunity at various levels. And all of this would reduce inflammation. The other mechanisms of probiotics would include binding and degradation of potential carcinogens, quantitative and qualitative metabolic alterations of the intestinal microflora, which again would then contribute towards regulating the carcinogens. Production of antitumorigenic or antimutagenic compounds that would again help. Competitive action towards pathogenic bacteria. Enhancement of the host immune response. This is very, very important. And it's believed that the small intestine, which has the longest surface or the largest surface area, has the least amount of cancer in the GI tract. In fact, organs that have least amount of immunological tissues like lymphocytes and lymph glands are the ones that are highest at risk. So esophagus, stomach, they have very high risk of developing cancer compared to the small intestine, which is extremely rich with immune cells. And then, of course, there are direct effects on proliferation. These are all some of the mechanisms. So the probiotics could reduce the reactive oxygen radicals, or it could interfere with other methogens that are produced by the bad bacteria and help in preventing cancer. These are mechanisms. Similarly, Helicobacter pylori, probiotics can affect the inflammatory component, it can help in eradication, and it can affect the various pathogenic mechanisms by which Helicobacter pylori would trigger stomach cancers. The literature review suggests that there is a lot of studies looking at the gut cancers. Obviously, probiotics work directly in the gut, and therefore that should be the most common site. Then there are some very interesting articles about probiotics and bladder cancers, oral cavity cancers, some in breast and cervix, and a couple of others in other sites as well. And I'll now go on to give you some real good evidence about the application of probiotics in cancer treatments. Theoretically, again, we can use probiotics in a number of situations. These are all opportunities for us to do further research. The most common being the complementary and alternative medicine, which almost 80–90% of cancer patients getting regular standard treatments like chemotherapy, radiation, and surgery would actually be taking some other form of complementary therapies. Most of our patients tend to take Ayurvedic and homeopathic treatments, try some other experimental therapies, and this is an area where probiotics could definitely be investigated, particularly to improve the quality of life of these patients. It can be used as an adjunct with other treatments, and there is a fair amount of evidence that probiotics reduce infections associated with cancer treatment, and I'll show you some of the examples. It can reduce diarrhea, which is a major problem during chemotherapy and radiation therapy, and mucositis again, which is a problem with chemotherapy and radiation therapy. There is a lot of interesting experimental work as well as some early clinical work on prevention. But as I showed you in the slide before, that to say that something is preventing, it takes a very long time. And we generally tend to use intermediate biomarkers or intermediate endpoints like proliferation index or mutagen production indexes to measure that probiotics are working. But I like to tell you that I use these intermediate products example. I tell my students, it's like Sachin Tendulkar hitting a century and India losing the match. So when you use intermediate endpoints, every time the intermediate is successful, it doesn't necessarily mean that your final endpoint will be achieved. And so that's why we have to be very careful when you interpret these type of studies. And from a preventive point of view, we can look at primary prevention. That means there is no disease, just an exposure, and then you are trying to prevent the first cancer cells developing. Then it can be secondary preventive mechanisms, like when there is dysplasia or polyp formation which has still not formed a cancer or is not spread. You can influence the course from it becoming a full-fledged cancer. And finally, of course, if there is cancer after treatment, you can try to use probiotics to prevent relapse. These are all interesting ideas, but let us see what the evidence would show. So there is good evidence that, like in all other sites, infection and probiotics, there is good evidence that probiotics help in infection, and particularly infection during chemotherapy, radiotherapy, and surgery. And I will just allude to the randomized trials. So there are 4 randomized trials looking at probiotics during radiation therapy at various sites, particularly the cervix and the pelvis, because that's where the intestinal loops, by virtue of its anatomical location, tend to be affected during radiation. Even with the modern techniques of image-guided radiotherapy, the loops are still not spared. And among these, one of the studies that I picked is the use of randomized controlled trial using lactobacillus and bifidobactam in the prophylaxis of diarrhea during radiation therapy. In this, like most randomized trials, unfortunately, the sample sizes are small, where patients were randomized to receive the probiotic compared to the controls, and they found that there is a very good control of diarrhea and mucositis in those who received the probiotic. Probiotics during chemotherapy, there are 3 randomized trials and 1 case control study, which again These are some of the studies, the randomized trials. I won't go into the details for want of time, and also it's a mixed audience. But essentially, this is one study that randomized patients who were receiving chemotherapy into by using a factorial design, using a fiber, a probiotic versus controls. And what you see is that the first column is the one that did not receive any of these agents, and then you have the column that received probiotic, and this is the combination, and this is the combination, that is the lactobacillus and fiber. And you can see for various toxicities which has been graded 0, which is white here, then you have black, that is grade 4 toxicity. So we are looking at diarrhea here. You can see that it is less in the group that received the probiotic or probiotic and fiber, and this is so I'm unable to see. I think you will also be unable to see this. I'm sorry about it. What this study showed really is that probiotics do reduce the complications of diarrhea, mucositis, and and the need for hospital stay. So a recent meta-analysis of all these studies, which I have just now alluded to, concluded that this is a systematic review of management of gastrointestinal mucositis in cancer patients. And they said that the panel said the probiotic treatment containing lactobacillus species may be beneficial for prevention of chemotherapy and radiotherapy-induced diarrhea in patients with malignancies of the pelvic region. So we have some positive results that would encourage us to pursue this further. Similarly, in surgical trials following cancer surgeries, infection is a big problem, and therefore there have been several randomized trials, about 9 randomized trials which have been done to reduce various complications, particularly the infectious complications. And there has been a meta-analysis. Following this meta-analysis, one more trial has been published, but I have not included that. So 9 randomized trials having more than 700 patients. So what did they find? Post-operative pneumonia, there is significant reduction in the post-operative pneumonia. OR is odds ratio. So you can see there is almost 75% reduction in the post-op pneumonia in patients who received probiotics. Cholangitis, infection of the biliary tract. This is particularly true for patients undergoing liver surgery, pancreas surgery, and surgery of the biliary tract. Again, there was significant reduction, almost 80% reduction in the cholangitis rates. Any infection, again, there is significant reduction. And so, finally, it all boils down to the use of antibiotics, the number of days this patient stays in the hospital and how much money is spent on this particular. And you can see that there has been a significant reduction in the hospital stay as well as the use of antibiotics. In other words, even in cancer surgery settings, the use of probiotics seems to be very helpful in dealing with the infection. So we have these randomized trials again reconfirm the effect of probiotics in controlling infections. What about other situations? But before I conclude that, I also need to tell you that these are patients who are highly immunocompromised, and they are not normal healthy people. And many years ago, about 14 years ago, we did a study looking at patients who are on intensive chemotherapy, all leukemic patients receiving various chemotherapies, and they are prone for neutropenia and neutropenic sepsis, to identify the important risk factors. And what we found in a small pilot study, was pilot study of 94 patients with acute leukemias, that if the food was handled by sick family members, there was an increased risk of neutropenic sepsis. If the patients were using live yogurt, dahi in India is made at home, and all one does is to put the previous day's dahi into the milk. And so if there are coliforms in that, it will come onto the next day's batch as well. And then the food handlers, their personal hygiene is so important. So we found that the use of the routine dahi increases the risk, whereas the use of fruits on a regular basis reduces the risk. We could not do a multivariate analysis because this is a small sample of patients, and we had planned to do a larger study, but then some of the ethics committee members felt that it would be inappropriate when we know now that some of them are risk due to poor hygiene and contaminated dahi, that we should be pursuing this study in a bigger way. So we actually switched off the study, and we are recommending now that on food hygiene and also to use the pasteurized dahi that will not be contaminated with various bacteria. So I think it's important that probiotics, when we use and we think of dahi as a probiotic, it's important that it can be contaminated and harmful to patients with cancer. Now there are a large number of trials looking at probiotics in the prevention of cancer, and this is much more complicated given the fact that there are so many other risk factors that operate at different stages during the carcinogenesis process, and carcinogenesis is a multi-step, long-drawn process. In this, I would like to pick on two studies for the want of time, and this is a study that looked at using probiotics along with therapy for patients with bladder cancers. The patients with recurrent bladder cancers, see, bladder cancer is an interesting cancer because it responds immensely to immunotherapy. The typical standard treatment for treating early bladder cancer is to install BCG in the bladder. The BCG induces inflammation, and that actually controls the bladder cancer. And so using the same principle, the role of probiotics in improving the immunity was studied, wherein the patients, if they had recurrent bladder cancers, received itamycin, which is a known anti-cancer drug, installation in the bladder, along with oral probiotic lactobacillus. And what did they find? Is that a 3-year survival rate for the arm that received the probiotic was 75% compared to 60% in the arm that received control. In other words, this was a positive study. There are failures as well. You can't achieve success all the time. There are going to be a lot of failures as well. And this is a study that looked at probiotics to prevent colorectal cancer recurrence. Mostly these are polyps. First adenomas develop and then they progress to cancers and then they metastasize. So polyp recurrence in patients who had previous colorectal cancer, so they are already high-risk individuals. And in this particular intervention, what was found is that there was no significant difference in the development of new colorectal tumors in any of the three groups. In this, they had a control group, they had a group with probiotic, they had a group with fiber, and a group in which it was combined. And there was really no difference. However, there was some evidence to suggest that the group that received lactobacillus casei had less severe type of adenomas in the recurrence. But actually, if you see, I think this is another technical issue about doing randomized trials for cancer prevention, and that is the sample size. I'm sure if this study was done with a larger sample size, they probably would have found that lactobacillus casei would help. We have very recently completed a large randomized trial, not randomized trial, a large case controlled trial looking at risk factors for colorectal cancers in India. Many of you may not be aware that India has one of the lowest colorectal cancers in the world. We have about 4 to 5 per 100,000 population across India, all parts of India. For example, if you were to compare two states where meat eating is very high, Kashmir and Kerala, and compare it with Gujarat, where the population is predominantly vegetarian, the colorectal cancer rates are the same in all the three states. Barring a few northeastern states where it is high, it is the same. So we did this study, and what we found, we were actually evaluating the role of vegetarian diet, and we have just found that it's a large study, almost 2,000 cases and controls. We found that people who are consuming dahi and dahi-like items have a reduced risk. But beyond this, I cannot tell you because the study is being fully analyzed with multivariate, which we hope to publish this year. I'm almost coming to the end. So there are a number of scientific issues related to the use of probiotics in various trials. These include which probiotic to use, how much to use, when to start, how long to give it, and in an era of personalized medicine, should we be giving it to all the people or only those who have dysbiosis in their gut? So how do we then identify those who are at the highest risk and intervene only in that particular group and not prescribe it to all the population where it is going to? There is an issue of blinding. How do you blind people? They know when they take probiotics. What kind of controls do we choose? And what are the endpoints, particularly in prevention trials? There is a very recent publication which suggests that the good clinical practice principles that is used in drug research should now be introduced in nutritional research as well. And this is going to complicate things even further in terms of the cost and in terms of the complexity. So in summary, there is good evidence showing that probiotic therapy during cancer treatment helps. There is some evidence that some cancers can be slowed down by the use of probiotics. There are lots of gaps in the future research, and there is very little data from India. What are the things that we could do in India to see whether the probiotics actually interact with the diets that we consume? Because our rich, I presume, is already high in probiotics. How does it work in malnourished patients? Because half of our population is malnourished, and if you're talking about immunity, then there is a very complex interaction between malnutrition, immunity, infections, cancers, etc. We have low cancer rates, so if we have to do randomized trials, we'll have to have larger sample size. That makes it even more difficult. And if you give probiotics for some time, how soon will the patient's flora get back to the original? We have no answers for these questions. Do we give it all along? Some common infections, like in cancer, for example, we have tuberculosis, varicella, which flare when they come on to chemotherapy because the immunity is down. Will probiotics help in such situations? Thank you for the patient hearing.
Thank you, Dr. Mohandas, for an excellent review of role of probiotics at various stages in cancer treatment and also in the causation. Now we'll open the topic for a few questions and comments. Yes, sir.
See, one of your graphs you showed that in Japan, the 50s, more deaths due to tuberculosis, and the case is reversed now. Is it for the same age group, or is it people becoming older and then they're dying of cancer?
No, those graphs are based on population-based age-adjusted rates. in different populations, the demography is different. For example, India currently has a lot of young people and very small proportion of old people, but it is projected 20 years from now, the young will decrease and there will be many more middle-aged and some more old people. So these graphs are actually adjusted for the age, sex, and the demography. But I didn't show for want of time, but similar graphs are available from the UK in the between 1880s and 1980s, and New York. Yeah. In New York City, in fact, if one looks at Osler's textbook of medicine, colon cancer is only one paragraph. Typhoid fever is 24 pages.
Dr. Rakesh?
Mohandas, you talked about really inflammation and cancer. But, the relationship of inflammation and cancer is really twofold. Inflammation does predispose to cancer, but at the same time, when you referred yourself to BCG being instilled in the bladder, we are actually trying to induce inflammation to treat cancer. So, can we really look at inflammation and say about cancer?
Yeah, I forgot, and we discussed this yesterday also, that I forgot to add the word, I should have put chronic inflammation, because that's really the problem, the inflammation that continues for months and years, rather than just an inflammation is one of the mechanisms of dealing with acute,
No, but at the same time, for the body to get rid of incipient cancers, immune system, which is really the same thing as inflammation, is an important factor. When you immunosuppress people, again, immunity and inflammation go hand in hand,
Yes.
isn't it? So, by suppressing inflammation, again, we are increasing cancer to some extent, isn't it?
if you suppress immunity, yes. On a long term, that's why AIDS people and people on long-term
Chemotherapy,
immunosuppression
yeah.
are at higher risk of cancer, yes. Yeah, so, that cartoon about the seesaw, I think if one can achieve the optimal balance, that would be it. It's like omega-3 and omega-6, the same debate goes on.
Dr. Mittal?
Does it prevent or does it
I don't know,
prevent?
I'm not an expert on probiotic, but I do believe that some of the ingredients in dahi is probiotic. I think the issue is about contamination. If you drink, contaminated things.
Did you do any study for showing the contamination? Because as I know, most of the homes, dahi is not used beyond 12 to 24 hours. Once it is made, it is not used beyond 12 to 24 hours.
Yeah, but it is
They
used
are
the
discarded.
next day. It is
No,
used
but-
to...
So within 24 hours it is used, sir. I mean, that is my...
No, but
but
it
have
is
you really
used-
done any study to show contamination of dahi?
Yes,
Because the only alternate...
following this, we did some sampling of the dyes, and to our horror, we found that there were coliforms. Some of them appeared to be hospital acquired because they were multi-drug resistant. So there was indeed contamination happening in the dye.
I think for want of time, I think we move on to the next.
So may I ask, a common man probably cannot afford a pre-packaged probiotic because it costs 45 rupees for about 250 ml. So
Yeah.
you said that it's not an ideal situation to carry forward the culture from the last, days to move forward. So what could you suggest as an alternative, if you can throw more light on that?
No, I am not an expert on economics, but I can tell you one thing. Common sense, healthy people can continue whatever they are practicing. My issue was during cancer treatments. During cancer treatment, the immunity really drops. And sometimes not so much, but in a patient like who underwent bone marrow transplant, there is zero immunity. And in them, we really cannot take chances because just one infection and the patient could be dead. So these are situations where we have to apply more science and be more scientific. In the routine environment, we can probably continue the same way.
Thank you.
I think if the question we'll discuss during the lunch break. We thank Dr. Mohandas for an excellent presentation. We move on to the next topic, that is the role of gut microbiota in diabetes. We have Dr. V. Mohan. Dr. V. Mohan is the chairman and chief diabetologist at Mohan's Diabetes Research Center, Chennai. And Dr. Mohan has been the receiver of the Padma Shri from the Government of India in 2012, and he has more than 745 publications. And over to Dr. Mohan, please.
Thank you, sir, for the kind introduction. I'd like to thank the organizers, particularly Dr. Nair, for inviting me to this meeting. I've been here since yesterday, only because I've come as a student to learn more from you. We just heard from Dr. Mohandas that when he did a search on PubMed, he found 19,000 references for probiotics and cancer. As you're speaking, I was checking it on PubMed for diabetes and probiotics. And if we just put the word probiotics and diabetes, only 122 references come up. And then when he was talking about randomized clinical trials, I put that, and only about 6 or 8 came up. And when I checked those 6 or 8, there was virtually nothing on diabetes itself. There's one on lipids and so on. So it's a very new field, not only for me, where I know virtually nothing about probiotics until I entered this meeting, but for us as diabetologists. And I don't think in diabetes societies, and I head the Research Society of Study of Diabetes in India, I don't think we even discuss this topic. So I'm very glad that some kind of cross-fertilization can come out of this meeting. And through my ignorance, I'll just try to take you through the little that we have managed to put. And I'm extremely grateful to my colleague, Dr. Balasubramaniam, who is in the audience, who helped me to put this slides together, and also some of the work which we will be presenting here today. So this is our Diabetes Institute where the work is done, and I thought I will also start, like Dr. Mohandas, with the epidemiology of diabetes, because this itself might give us some clues about the role of microbiota. For example, if you look at the prevalence of diabetes in India from the 1970s up to 2009, and these are figures for the urban areas shown on this side, and on the right side you have the rural areas. You can see that despite all the limitations of the studies, and we have good studies for the last 40 years, there have been piecemeal studies done in one village, one city, at different times, different cut points have been used, different sampling frames have been used, and so on. So really not comparable. You really can't even put them into a table. But having said that, if you look at it, it's fascinating that it actually goes from 1, 2, 3, 4, 5, 6, 8, 10, 12. It almost kind of numerically increases. And therefore, there's no doubt at all that the prevalence of diabetes is increasing in India, that it's reached endemic proportions. Some people even call it as pandemic. And the bad news is that it was considered a rich man's disease. It's no longer a rich man's disease. It's moving to the middle income group and to the lower income group. It was considered a disease of old age. It's no longer true. We are seeing type 2 diabetes in children. My youngest child is 7 years old and has type 2 diabetes, not type 1 diabetes. And it's no longer an urban phenomenon. It's also becoming a rural phenomenon. As you can see, from the 1%, it's even going up to 14, 15% in Kerala and 18% in rural Andhra Pradesh in one particular study. But as I said, these studies are piecemeal. They have not even looked at one state of India. And therefore, when my daughter came up with an idea, and she's the greatest critic at home can be your wife and your daughter. And this girl, when she was doing her post-graduation, she came up to me and said, we really need to do a pan-Indian study. And I said, not we, you do it, because we can't do a pan-Indian study. India has 1.2 billion people. The cultures are so different, so difficult to do a pan-Indian study. So anyway, to cut a long story short, we're actually doing the study now. And this is called as the ICMR India Diabetes Study, or the INDIAB study, the primary objective of which is to determine the national prevalence of diabetes and pre-diabetes in India by estimating the state-wise prevalence of the same. Why did you have to go state-wise to pick up a national prevalence? And that was given yesterday, I think by Dr. Chandramouli, who said that in India, health is a state subject, and therefore, whatever you do by terms of the prevalence of diabetes in India, each state wants to know what the prevalence is in that state. And therefore, ICMR in its wisdom said you do the whole country, state by state, however long it takes, and that's how this study, which when completed will be the largest epidemiological study ever done in the world, 124,000 individuals, representative of the 1.2 billion people in this country. The planning itself took more than a year. And where are we today as far as the study is concerned? It's progressing along quite well. The first 4 states were completed what is called as the phase 1 of the study. We did Tamil Nadu in the south, Maharashtra in the west, Chandigarh in the north, and Jharkhand in the east, and then went on to look at the 8 states of the northeast, where we just completed Assam and Mizoram, and we are currently working in Tripura and Arunachal Pradesh, and almost simultaneously 5 other states in the northeast in the rest of India has started with Andhra Pradesh, Karnataka, Gujarat, Punjab, and Bihar simultaneously going on. So we're now working actually 6 states simultaneously, and we hope to complete the study by next year, or at least in a year and a half from now, if we continue the same momentum. So what did we find in the study? When we finished the first phase of the study, which is just these 4 states that I told you, it looks very small from India's point of view, but that itself represents a population of 218 million people. There are only about 6 or 7 countries in the world which have a population more than 218 million people. So we decided to publish it at that stage because the epidemiology is changing so rapidly that we really can't wait until we finish the whole study. So the numbers which came up from this study is 62 million people with diabetes in India. From these 4 complete states, representative samples, we then used the weighted prevalence to project for the rest of the country. And what is worse is that we now know that there are 77 million people with pre-diabetes, which means that the epidemic is not over. In the short term, it's going to increase very rapidly, because we also know from published evidence that Asian Indians, South Asians, have one of the fastest progression from pre-diabetes to diabetes, much faster than in the Japanese or the Chinese or in the white Caucasian population. Just one more slide on the epidemiology, just to show you. I just asked, is the epidemiology of diabetes the same in different parts of the, Dr. Raghunath just asking me that, and this answers that to show you that there are huge differences within India. So if you, for example, you look at Jharkhand, urban and the urban Tamil Nadu, they are virtually the same, because urban Jharkhand is highly urban. It's built around the cities, the factories, towns where they develop, and therefore the standard of care is very good, the screening is very good, and therefore the prevalence rates are very similar. But if you look at rural Tamil Nadu, where it's close to 8%, it's only 3% in Jharkhand. So even within India, there's considerable heterogeneity, and I would propose to this audience, could some of that heterogeneity be actually explained due to differences in gut microbiota, because of the food which is traditionally eaten is different in different parts of the country. For example, rice being eaten in the south, wheat or millets being consumed in other parts, and so on and so forth. The bigger worry that we have about diabetes is not that the numbers are increasing, but that the burden due to diabetes is very rapidly increasing as well. From the Chennai Urban Rural Epidemiological Study, where we studied the whole of Chennai, we were able to get accurate data on the complications of diabetes. And here are the numbers for coronary artery disease, peripheral vascular disease, retinopathy, nephropathy, and neuropathy. And I'm not going to go into the details, except to tell you that when you talk about individual complications of diabetes, you just take kidney disease, for example, 17 million people in India with diabetic kidney disease. And for nephrologists who may be in the audience or from the work of Dr. M.K. Mani, you know that only 1 to 2% of people with end-stage renal disease can actually afford to have either dialysis or transplantation, both of which are prohibitively expensive. And therefore, the only thing you can do is to prevent diabetes. And therefore, if probiotics can even give a faint glimmer of hope that you can prevent diabetes, why not? You should be attempting that as well. The next point that I want to talk to you about, which is again of interest from a research perspective, is the Asian Indian phenotype. We know that the South Asian phenotype, or the Asian Indian phenotype as they called it, is a little different from the Western type of diabetes. Because A, we have a very high prevalence of diabetes. B, it appears to come at a much younger age group. C, despite the not so obese rates, the obesity rates being much lower in our country, we still seem to be prone to get diabetes. So we have debated for years whether this is, and there are other features. For example, the higher insulin levels, which I first described in 1985, and then the characteristic dyslipidemia, the increased abdominal obesity, particularly the visceral fat, the decreased levels of adiponectin, the higher HSCRP. These are all features which have been confirmed by many, many groups in not only in our country but abroad. The big question which we have been asking ourselves all these years is it due to genetic factors or is it due to environmental factors? And I will not belabor this audience with the results of the genetic studies which we have done, except to tell you that there are some differences, interesting differences. For example, in a Nature Genetics paper published last year, we came across 6 novel genes in South Asians which are replicated in several South Asians across the world, but not found in any other race in the world. And therefore, there are genetic differences. But the epidemic of diabetes must surely not be driven by genetic factors, because the genes didn't change in 30 or 40 years. When you saw from 1971, 1% to almost 20%. This is due to environmental factors. And again, working on concepts such as, is the rice intake, the white rice, polished rice intake related to the epidemic of diabetes? We have strong epidemiological evidence for that, physical activity, depression, and other environmental factors. But the question I would like to raise from today onwards, as a result of this meeting, is, can gut microbiota also, at least in part, explain this ethnic susceptibility to Asian Indians? And this is an area which we haven't worked on. Where does a gut actually fit in as far as diabetes is concerned? A few years ago, life was very simple because we just talked about the beta cells and insulin. We talked a little bit about the liver and insulin resistance, and a little bit about the muscle or adipose tissue, another site of insulin resistance. So we thought that we called it as the triad of diabetes, the 3 organs which went wrong. Professor Defonso, the guru of diabetes, recently in his Banting lecture said that, hey guys, there is much more to diabetes than this. The triad that you're talking about, the triumvirate you're talking about, we're not talking about the octet, the ominous octet of diabetes. Many more organs have been thrown into the fray, and here we have the gut also prominently figuring here, along with the kidney now a new player, the brain, the alpha cells now coming in, and so on. And the gut, the situation so far has been looking at the gut from a different angle, looking at the gut hormones. And yesterday somebody was saying, don't forget the hormones when you talk about it, quite rightly. I think Dr. Alvar was talking about it yesterday. Yes, the role of the GLP hormones and the GIP and so on, and how the DPP-4 inhibitors and the GLP-1 analogs, this has become a big field. For example, we'd completely forgotten about the alpha cells of the pancreas and always talking about the beta cells. Once the GLP hormones came, we know that hyperglucagonemia is one of the defects, and if you can reduce the glucagon levels through the gut, then you can reduce diabetes. And that's how the gut and diabetes came into play as far as diabetologists are concerned. In fact, the gut connection goes a little beyond that, and as has been discussed when the previous speaker spoke about chronic inflammation and so on, we know that in diabetes, 2 major defects are there, and one is oxidative stress, and the other is inflammation, both of these coming from metabolic endotoxemia. And through a series of elegant studies done by Dr. Balasubramaniam, who is in the audience, and his team, we have shown that there is definitely evidence of oxidative stress in various publications that we have shown. Through another series of publications, we've also shown that chronic inflammation, this is not acute inflammation, chronic inflammation, very much related to cancer, is also present in diabetes. Now, how much of these is related to the gut microbiota has not been studied so far, and this obviously should be one of the areas we should focus on in the future. But coming back to the gut now seems to play an increasingly important role, not only in fat storage, energy metabolism, the fat leading on to hepatic steatosis and the so-called non-alcoholic fatty liver disease, which today people consider to be a part of diabetes, but also directly for cardiovascular disease, various vascular changes, the brain, and indeed even the pancreas and diabetes. We also know that a simple thing like feeding a high-fat diet does many things into the gut. For example, it decreases the good bacteria, the bifidobacterium. It also increases the macrophages. And one of the key players which has been brought into this is the lipopolysaccharides, or the LPS, which is supposed to act on the liver, on the adipose tissue, and on the muscle and so on, producing insulin resistance, and this insulin resistance can, of course, lead to diabetes. Do we have evidence for the converse, that if you feed prebiotics or probiotics, you can do that? There is some evidence that you can, in fact, reduce the LPS, you can increase the good hormones like the GLP-1 or the PYY, and decrease the bad ones like the ghrelin and so on, and therefore reverse many of these abnormalities which I showed you in the previous slide. But yet the evidence for this, as I said, is very, very thin, and we need to develop that evidence. Endotoxemia has in fact been shown to be in a recent paper to be associated with an increased risk of incident diabetes. And when we talk about the lipopolysaccharide, we know that it can work in two mechanisms. One is by facilitation of the chylomicrons, and the second is by the loss of the intestinal tight junctions. So when you break these tight junctions down, then the endotoxemia can spread. Surprisingly, when we reviewed the literature, we found that there were very few reports, virtually none, on measurable LPS levels in people with diabetes and without diabetes. And therefore, in one of the recent experiments which Balu's daughter actually did as part of her thesis, which she recently worked with us, she showed that the patients with type 2 diabetes had demonstrably increased levels of LPS compared to the control age and sex-matched non-diabetic subjects. What she also showed was a nice ratio, the ratio of the LPS by the HDL ratio. We know that the HDL cholesterol not only clears the LDL from the circulation, but it also clears the LPS from the circulation. So if you measure the LPS by the HDL ratio, there's another good index, and we found, not surprisingly, that this ratio was elevated in patients with type 2 diabetes. Directly coming to the gut microbiota and adults with type 2 diabetes, there have been studies which have shown the various, the friendly microbes, the Firmicutes and the Clostridium, were specifically reduced in diabetic groups compared to the control groups, whereas some of the pathogenic microorganisms are increased in people with diabetes. There's another study in relation to the metabolic syndrome, very similar results shown in the gut microbiota in the older order Amish population. But we all know that you cannot culture these organisms, and we've spoken about this several times during this meeting, that metagenomics is very important. And surprisingly, there's only been one study on metagenomics published literally last week in Nature, where a large collaborative group, particularly with Olaf Pedersen and others, top scientists in this, who have shown that there are, in patients with type 2 diabetes, there's a moderate degree of gut microbial dysbiosis and a decrease in the abundance of some of the universal butyrate-producing bacteria and an increase in the various opportunistic pathogens. This is a landmark paper which needs to be replicated and taken forward. From India, we have heard about the elegant studies yesterday from CMC Velo, and Dr. Ramakrishna presented that, and we also had the presentation yesterday evening. Dr. Balakrishna Iyer has shown the metagenome of the gut of a malnourished child. There was a recent paper from Pune, which is one of the first looking at metabolic diseases, and this is the molecular analysis of gut microbiota in obesity among Indian individuals. Unfortunately, there's no data or studies on gut microbiota in relation to diabetes from India, and therefore there's an urgent need for research in this field. We have done some preliminary studies, and I'm very happy to present this with the help of our collaborators, Dr. Batish and Dr. Sunita Grover from the National Dairy Research Institute, Karnal, where what Balu and his team have done was to feed mice with normal pellet diet and with a high-fat diet called as HFD. But the high-fat diet had different arms in it. One, we had a positive control where lactobacillus was used, and the other where these two probiotic cultures obtained from the National Dairy Research Institute were used, which we call as SG1 and SG2, and then metformin was also used. And here are the results of that study, where you can see these are the glucose tolerance. This is the glucose tolerance of the rat fed the normal diet, and you can see that the glucose tolerance considerably worsens when you feed them with, when you actually induce the diabetes here with a high-fat diet. And then when you look at the positive control, the lactobacillus which is used, as well as the two culture, the probiotic culture strains which we used, you can see a significant improvement in the glucose tolerance curve. And if you look at the area under the curve, you can see that it's considerably diminished, showing you, I think, an experimental evidence that the glucose levels and the GTT can actually improve by using these probiotic cultures. We also looked at the insulin tolerance test, and you can see the insulin tolerance, the insulin sensitivity has considerably decreased in these in the same rats after feeding them on the high-fat diet. But you can see that once you have treated them with the positive control, the lactobacillus, as well as these two probiotic cultures and with metformin, a near reversal or an improvement in the insulin sensitivity in these acute experiments. We are extremely fortunate to have a collaboration with Dr. Balakrishnan Nair's group from the Translational Research Institute in Delhi, and Dr. Sharmila and Dr. Bhavatosh is also here in this audience, and that's our group. And in collaboration with the TCS, with the Sharmila Manday's group, and also in collaboration with Dr. Olaf Pedersen. There's an Indo-Danish proposal, and we've just got the news as of last week that this project has been funded, and this project is called MicroDiab, and it will have an extensive study of the interactions between the gut microbe and the human host biology to elucidate normal aspects of the pathophysiology and pathogenesis of type 2 diabetes. This will be based on human trials. The real challenge, ladies and gentlemen, is to apply these metagenomics and integrative metabolic approaches to better understand the underlying causes of metabolic diseases in the context of gut microbiota, to develop novel, and this will of course lead on to develop novel therapeutic options, including targeting the drugs for microbial genes, or co-regulated host pathways, or modifying the gut microbiota either through diet, which is what we are here about, but possibly through other mechanisms as well. We know that bariatric surgery, when you do bariatric surgery on someone, that's a direct demonstration that the gut is doing something. You do bariatric surgery on someone who requires 150 units of insulin, has uncontrolled diabetes, and in 24 hours the diabetes is gone. Long before anything has happened. There's no weight loss, nothing. What's happening there? We still don't know. Whether it is related to the gut, or it's due to hormones, or it's due to microbiota changes, we really don't know. And also the question of fecal transplants or ecological engineering. I'm therefore very excited to be here today, and I would like to tell you that a whole new field looks as if it's waiting to be explored. Thank you.
Thank you, Dr. Mohan, for an excellent presentation and also giving new insights into diabetes and probiotics. Few questions from the floor.
Dr. Mohan, if I listened you correctly, you said that you want to see you see this Asian Indian genes have not changed, as you said, and but the diabetes is increasing, but you want to explore or examine this phenomenon in terms of gut microbiome.
Yeah.
How you propose to do that? Because how will you know what was the gut microbiome profile when the incidence of diabetes was low? What will be your comparator?
We have three groups. We have a group of normal glucose tolerance individuals. We have a group of people with pre-diabetes, and we have a group of people with diabetes. So one will act as a control for the other within India. And we have a similar group in Denmark as well. So two things will come out from this. One, we'll know at a cross-sectional level whether the gut microbiota of the person with diabetes differs from pre-diabetes and the control group. The hypothesis is that if at two ends, the diabetes group and the normal glucose tolerance group, if there's difference, then the IGT will come in between, the pre-diabetes will be in between. It will also answer the question whether, since we're doing the similar studies in Denmark, where also some mechanistic studies will be added, whether the differences between Denmark and India could be explained by some of the gut microbiota. So that's what we're trying to do.
The second quick question is, in the first table you showed, in 2004, there's suddenly a drop.
In the diabetes?
Yes, it was...
Well, I told you those studies are not really comparable because they have done, and one or two of those studies actually, one has used only fasting glucose, one has left out the towns. So a lot of, in the first slide that I showed you, there are a lot of problems with it. And that's why the ICMR index study will answer that. Because it's an identical sampling frame everywhere. The same individuals will be selected at different households using the WHO KISH method. Only one will be selected from the household. The same GTT will be done. The central lab is being used, and therefore the most standardized manner is being done. So any differences within the ICMR and DIAB study can be explained as true differences. Of course, we're also collecting data on diet and physical activity and so on. So we'll get much more than just the prevalence of diabetes. Yes, sir. breath smell, you're talking about halitosis? Halitosis? Or I'm not sure that it really, the breath smell is different. I know there are differences in the carbon. If you measure the carbon of the breath, there are differences. We also know that once the acidosis sets in, diabetic ketoacidosis, then you get the fruity odor and the smell completely changes. But in a routine common garden type 2 diabetic patient, I doubt very much. Probably periodontitis. More common things. Yeah.
But I thought that there could be some correlation between...
It's a good suggestion. We'll think about it.
Because you said that there is a difference in the microbiota of the diabetic patients.
There seems to be, yes, but very little data though.
Maybe probiotic could solve that problem.
Sure, might.
Thank you.
Yeah, it might even directly reduce glucose levels. That's what you're hoping.
Yeah.
Yes, sir.
Thank you. That was an excellent talk. I have a question and a concern which I had raised it yesterday also, that when you do a lot of this cross-sectional analysis of data, we come up with questions which may have a lot of background noise, if you know what I'm trying to say. So it would be interesting at some stage, maybe after you've generated some hypotheses from the cross-sectional data, to take it up in a longitudinal way, because there would be just so many interactions in the variables and in the background information that you collect. So
I entirely agree with you, and these are the drawbacks of a cross-section study. But having said that, if you have a very large sample size and you do things in a proper way, many of this background noise will get reduced. We are also lucky to have with us some NIH-funded studies now, which are supporting for the next 10 years longitudinal data in Chennai. That will be only Chennai though. We can't prospectively follow the whole Indian cohort. It's too much. So, but within Chennai and also in the rural areas in and around Chunampet and 42 villages which we're working in, we do have prospective data. And from that prospective data, we're going to have year-on-year follow-up results, and for the next 10 years we'll have. So we had not really included things like gut microbiota and that. But if it's possible to mount, that's why the first cross-section study is going to be done now. But based on what we find, then we should take it forward. The only problem is the cost of these studies. These studies are so expensive. The deep sequencing is almost prohibitively expensive, that until the costs come down, it's going to be a great challenge.
no, I completely agree, because we are struggling with the same kind of, with our young infants and neonatal associations with gut microbiota, because at the end of the day, if you want to see an effect from a cause, then that's what will help you to...
Yeah, sure. But your point is well taken. Yeah.
I have a small question. Most of the commercial probiotics have carbohydrates, that is added sugar around 15 to 20%. Then how this commercial probiotics will be applicable to diabetes patients?
Yeah, I would like to throw that back to the Yakult Foundation, because I drank it yesterday and it's extremely sweet. So I don't think we can recommend this for people with diabetes. And so you have to have sugar-free, completely sugar-free. I entirely agree. So it's not meant for diabetics.
Yeah.
Yes, sir.
Actually, I have two. One is that this epidemiology of diabetes is linked with the decreased number of famines as far as this country is concerned.
Famines?
Yeah.
You're talking about the low birth weight.
Cycles of famines that used to take place in India. We don't have that anymore. Any variation is looked after. To what extent there is matched? That is one. The second is, would you recommend surgery for diabetes, chronic diabetics?
Bariatric? Bariatric? Or? Yeah. We have just started our obesity clinic, and we're just starting our bariatric surgery, and it took a long time for me as a diabetologist to accept that. But I think there is no go but in a set of people, in a highly selected group of people who have BMI of 40, 50, whose insulin doses go to 200 units per day. Nothing works. Absolutely nothing works. And miraculously, you operate on them and the diabetes goes away. They say, okay, it'll come back after 5 years. I don't care if it comes back after 5 years. If it comes back after 5 days, I don't mind. Because these are guys who cannot get their sugars under control anyway. So there is a group of people who will respond to bariatric surgery. Getting back to your epidemiological question, Well, that's exactly what's happened. From the undernutrition and the famines that we had, now we're moving to overnutrition. We're having children who are not malnourished but who are obese in adolescence. And so that is really driving the epidemic. Now, whether it is due to the low birth weight, which Dr. Yajanik and others have worked on, and only they will develop diabetes in the future, or everyone will develop it, to me, that I don't think that question has been fully answered. It stands to reason that if you're a malnourished child, you're born with a smaller pancreas, and you're born with everything else reduced, you will definitely be at higher risk. But I think even independent of that, if you put on weight, you get diabetes. And so you really don't have to be in the malnourished stage to catch up. It will be worse, I suppose, if you get that.
We thank Dr. Dr. Mohan for his excellent talk, and we move on to the next topic. Role of probiotics in improving amino acid uptake. We have Dr. Anura Kurpad, who is the head of Division of Nutrition and Professor of Physiology at St. John's Medical College Hospital, Bangalore. Over to Dr. Anura.
Thank you. Thank you for inviting me here. And I was telling Dr. Mohan and Dr. Mohandas that following them is a hard act, but I'm going to try my best. And I'm going to be talking about nutrition and amino acids, which has a bearing on the whole business of muscle mass, sarcopenia, and in its own way towards glucose disposal. Now, I will make a small correction. I am talking about the role of intestinal microbiota and not probiotics as yet, although that's something we may consider in the future. Now, if you do a search on Google and look for microbiome and The Economist, the magazine, you'll find this nice article which actually reviews a lot of the things that are known about the microbiome. Obesity, of course, is such a big area which is so well researched. But one important thing that this article also does review is that malnutrition is also associated with specific microbiomes in some very interesting twin studies. This is really important, and this relates to some of the things I'll be talking to you about. And of course, the important thing is, how do you change all this? You can only change it by antibiotics. You can change it by transplanting the microbiome. But the question is whether you can change it significantly and permanently by feeding probiotics is the key question. The fact is that the microbiome is in a state of dynamic change. There's some very nice experiments which looks at how the microbiome changes not only from species but from the very nature of the bacteria being anaerobic to aerobic, depending on whether ileostomies were present and oxygen was available, and back after the ileostomies are closed. So this shows that this microbiome, we speak of it almost like a kind of static set of bacteria. They're extremely dynamic. And I think that should be at the very basis of what we talk about. I think these flora, now let me just move towards what I'm really talking about in this lecture. These are very important in the newborn. Those of you who have looked at the analysis of human milk will be struck by how little protein there is in it. There is a fair amount of nitrogen in human milk, but the protein is only about 70%. The rest is urea. And as Dr. Ramakrishna showed yesterday, the human neonate is born and on the very first day is almost completely colonized. And in fact, it is thought that these bacteria are very important in helping the newborn utilize the urea. Otherwise, if it just were to utilize the protein, there would be protein deficiency in breast milk. But nitrogen is adequate. It also helps in breaking down glycans in breast milk. The other two things that I want to sort of focus on is, because I'm talking so much about amino acids and protein, it's important to know that although we'd love to have it, there are not many amino acid transporters that we know of in the colon. In fact, absorption of amino acids from the colon is unknown, although if you look at some reports in rabbits and other mammals, there are some transporters of amino acid in the colon, but in general, we would say that there is no transport from the colon. So there's no point making amino acids in the colon. If you're going to make it, it's got to be made in the small intestine. And you have just about 5 hours to 6 hours to make it before the matter has passed through into the colon and it's not available. I think a similar consideration exists with vitamin B12. There's a fair amount of deficiency in this country. There's a fair amount of deficiency in vegetarians in general, and there's definitely a risk of deficiency in vegans who don't even take milk. But from Vellore, there was this suggestion made in the 70s that there could be some amount of B12 that is being synthesized by bacteria in the small gut. And the research in this area hasn't really taken off that much. And to that extent, the B12 story remains a possible mechanism. And we don't want to discount it by any means. But the protein story has become a little more relevant as we have moved on. The protein story starts with how we have always thought that the protein requirements in man are not that important. So if you looked at the 1985 recommendations of the FAO and the WHO, it suggested that the requirements of the essential amino acids that are listed here were quite small. In fact, they were so small that one could just eat plain rice or plain anything, and you'd get enough protein. To that extent, it also explains a lot of the policies that went on in agriculture, which pushed the development of cereals rather than protein sources as an important issue. However, in about the 90s and 80s, there was a suspicion that maybe this wasn't right, and a great deal of research happened around the 80s, 90s, and the zeros of this century, and subsequently, we all realized that the old data was based on measuring nitrogen balance, and those of you who have measured this will realize it's an extremely difficult thing to do. And based on a lot of new techniques that were partly developed at MIT, partly in Canada, and partly right here in Bangalore, we developed methods that actually helped us redefine these amino acid requirements. And in 2007, they were accepted as the primary evidence for the WHO to change the recommendations. And you'll see on the screen that all the requirements have gone up, but I've highlighted lysine because in most diets that are based on cereals, lysine is limiting. It's the first limiting amino acid, and threonine is the next one. And you can see the lysine requirement has gone up quite enormously. And based on this, then you begin to think, let's do some surveys and understand, are there deficiencies in lysine intake? And yes, there is. In low socioeconomic people, for sure, there is a deficiency. In rural children, it's about 50%. And you have to consider that when one grows, one's protein deposition is based on having an adequate quality of protein. And if you don't have that, one of the possibilities is that you will have a deficient protein mass. And the most plastic of all the protein masses is the muscle mass. And there's no doubt that Indians, right from the time about 1.5 centuries ago, when the first reports that I have read of Indians and their muscularity was written by Richard Burton, the traveler, and he said they were shockingly scrawny and thin, and they had no calves on their legs. And that continues today. The only difference is that we seem to have padded out our calves, our low muscle frames, with little fat. And that's where this whole conundrum of the thin fat Indian comes up, because you're packing fat on a fairly sarcopenic frame, and that is the point. It is not just about putting on fat, it's putting it onto a thin sarcopenic frame. And we have to understand how muscle is important and how protein affects that muscle. And there have been several studies that have subsequently been done on lysine, and giving lysine in the community is very difficult, because if you want to study lysine deficiency, you have to find a lysine deficient population, and it's got its own problems, because there was a recent survey that was recently done, a market survey in India, that showed that the spend on proteins in rural areas has actually increased massively to to the extent that if you took the whole of India as an aggregate, the rural spend on protein is now more than the spend in cities. So there have been several studies that have been done anyway on lysine, and it's been very hard to show an effect. Some of the intervention trials we have done have actually shown a small benefit in terms of muscle strength, but it's very hard within a small study to actually show an increase in muscle mass, because the biggest thing that drives muscle mass is exercise. So it's a very complex thing to study. Nevertheless, to come back, there were these studies in Papua New Guinea, on the highlanders of Papua New Guinea, where they subsisted on very starchy diets with very low protein, sweet potatoes mainly. And their intakes could have been about 35 grams of protein per day for a fairly big person who should have been eating double that amount. And the point, they were not losing weight. They in fact continued to go and hunt animals and eat and do what they could. And these were actually studied by investigators from Tokyo in a couple of very nice studies, which showed that they didn't have a negative nitrogen balance. Now, if I put people on a low protein intake, it is quite likely that over the next week or two, those subjects will begin to excrete more nitrogen than they eat into them through that low intake. The subjects from Papua New Guinea had a normal, zero nitrogen balance. How did that happen? They had a low urea excretion. How did that happen? They probably had a low urea production. In addition, they were probably reutilizing their urea. And this suspicion has been there for a long time. From the 1950s and 60s and 70s, it has often been thought that there are bugs in the colon that reutilize urea, because urea is a small molecule, it diffuses everywhere, it gets into the gut matter, the bacteria there can use it as a source of nitrogen and grow on their own. Problem? You can't recycle that nitrogen as amino acids if it happens in the colon. It has to happen in the small intestine. And then there was this paper in the 1970 that came out by an Indian called Tripathi, who was working out of New Orleans and in Colombia, in Cali, Colombia, where they actually gave urea to malnourished patients in Colombia and were able to show that it improved their nitrogen balance. And this is fairly shocking, because you kind of think, gosh, does that mean now we can feed fertilizer to human beings and make them okay? Because that's what urea is. It's not true, obviously, but to an extent it can help. And that's the point I'm trying to make here, that it is possible to an extent that you can recycle the urea that is produced from your liver in the bloodstream, diffuses into the intestine. You can recycle that because the bacteria use it. The bacteria can then secrete things, or they could break down and die and break down, and you could reabsorb preformed essential amino acids which did not come from what you ate. Question, how much of this happens and where does it happen? The important thing is that I think this may be important, because given the high requirements of amino acids, given those high requirements, and the fact that there's so much of widespread stunting in this country, and the fact that protein intakes are related to height in many large surveys that have been done, and the fact that actually the environment can make your lysine requirements even more. For example, intestinal parasites can increase lysine requirements, as we have shown. And the fact that when you eat amino acids, not all of them are absorbed and get to the liver. 20% are used on the spot by a very rapidly turning over intestinal mucosa. And a rapidly turning over intestinal mucosa is extremely important for good absorption of other nutrients. So these are all interactive things that are very important in this consideration. So here's how the scheme goes. If you actually look at it, that this is a section of the small intestine, dietary protein goes in, and it can be broken down to amino acids or lysine, whatever you want. But there's urea from the body going into the intestine, being used, bacterial growth, they secrete or break down, and their products can get absorbed as preformed amino acids or lysine. What you've done is you've recycled urea, and we always thought urea is an excretory product. We don't need it. And the important thing is that the large intestine has no absorption of this lysine. Now, is there proof that this exists? One nice way to give this proof is that you can take babies or you can take adults and you can give them, urea has 2 nitrogens in it, so you can put 15 Ns or isotopes onto those nitrogens and feed them to a human being. Now, that 15N, double 15N labeled urea must be excreted as it is. If you find that you're getting single 15N urea being excreted, it means that somewhere in the body there's hydrolysis of that urea, and once it's hydrolyzed, it's being used, and it's creating single nitrogen labeled amino acids. Those are being absorbed and broken down by the liver to form single nitrogen labeled urea. In fact, this does happen. There's an appearance of single nitrogen labeled urea in both children as well as in adults, and there are other ways to do it by actually giving stable labeled ammonium sulfate or urea by mouth into the body and measuring how much of labeled lysine, for example, appears in the plasma. Very difficult experiments to do. And this is a difficulty in the experiment because although you can measure the amount of labeled lysine coming out of the plasma, you have no idea as to how much is coming because you have no idea as to what the enrichment of that precursor was at the point where synthesis was occurring. And unless you know that, and that means you have to put a very long tube down into the gut and take samples, as they do in some labs around the world, but not here. Very difficult to get those tubes down. And as a result, you're just guessing. Because you can't take a fecal sample to measure what's happening in the small intestine. You get extremely wrong answers with all these things. So one of the things that we've been doing is, as I said, we worked on making a kind of new approach to measuring amino acid requirements, and we developed a kind of a breath test, if you want to call it that. It's just taking breath samples. And we basically said, can we reuse this kind of strategy to measure the amount of any indispensable amino acid being formed? And the strategy is this, that if you actually give the body more and more amounts of an amino acid, you will find that because the body can't store amino acids beyond its requirement, it will detoxify them, it will oxidize them. So you'll find that there's an increasing oxidation as you give more and more amino acids. And therefore, if you actually look at, say, for example, studies of leucine, as you increase leucine intake beyond the requirement of 40, you'll find in a number of studies published around the world, which I've collated here, there's a beautiful increase, a linear increase in its excretion. So what did we do? We kind of used this method. We fed subjects 2 different levels of leucine at different levels of the RDA of leucine. And we find that, yes, as you feed more, the leucine oxidation increases. Not a big deal. But remember this, that we then would actually give these subjects an antibiotic to reduce the amount of gut bacteria. And if you reduce the gut bacteria, you will reduce the contribution, if any, from those bacteria into the leucine pool of the body. And if you reduce that, the oxidation levels would go down because the level of intake into the body goes down. And because you have this beautiful system, you could actually read off as a slope measurement the actual quantitation of input from these bacteria. It's just a breath test. And when we did this, you will find that actually the slope will come down because at both levels the oxidation will fall, and you can actually figure that one out. And this is what we got in a study in which we actually gave leucine at different levels. We gave ciprofloxacin and we gave an antifungal so that there wouldn't be a fungal overgrowth. And we found that post-treatment there was about 20% reduction in leucine input into the body. So effectively, this was one of the good quantitative measurements that actually showed that you could have a significant input by the bacteria in the small intestine for leucine and by extension for the other amino acids. And I don't think there's been another indirect study like this that's been done. It's usually done in ileostomists who have already an access into the small intestine, but those are very difficult because ileostomies change the nature of the bacteria and the small intestine. This is actually an intact study. Now, this by itself is extremely gratifying because it tells you that your intestinal bugs can actually shift the curve of your intake to the right. And as a result, if you look at that red line there, which is the estimated average requirement of lysine, the area under the curve to the left of that line becomes smaller and smaller. So the risk of low intake of lysine begins to drop as you have these bugs doing their work. And you immediately think, if that's the case, can I not use this as a way to meet the requirement? Just like those Papua New Guinea Highlanders were supposed to be doing. They were also recycling their urea, although it wasn't measured there, it was just guessed. But maybe that's the way that if we could actually provide some more energy, give these bugs what they need, maybe they can make a little factory in the small intestine, and then you don't really need to give amino acids that much. Don't worry so much about it, at least. As we used to not worry in the days of the Green Revolution, maybe we can go back to not worrying about it. Well, so we did the experiment. What we did was we actually gave an extra amount of energy to these subjects, to our subjects, and we gave them resistant starch because we just thought, let's make sure we feed those bugs and not the human being. And we did these experiments and found actually there was no effect. No effect at all. You couldn't tell these bugs what to do. And then we thought maybe the resistant starch was just too resistant. Because, resistant starch can be made to be extremely resistant. It takes time to break it down. You only have 5 hours. So we actually used a softer fiber like pectin. No effect. So this has really then humbled us to think that, there's lots to consider in this whole matter. The fact is that in Indians, we eat a lot of starch and non-starch. Now, there have been studies from the Mayo Clinic onwards where long tubes were put down right all the way to the ileocecal junction, and someone measured, is there starch entering the colon? And yes, that was in the days before resistant starch was actually defined. 20% of the starch was found, intaken starch was found to be entering the colon anyway, in addition to the non-starch polysaccharides like fibers that you were eating. So in India, we eat a lot of starch. A lot of the food is cooked, cooled, cooked again, and how much of it converts into resistant starch, we do not know. But nevertheless, it must exist, because there was a study when I was a medical student. I remember we did a study on increasing starch intake in our medical students, and when we gave them increased starch, their fecal weights increased. Now, if we gave them increased starch, you'd expect that they would use the starch and increase their weight because energy levels had gone up. No, fecal weights increased, meaning a lot of the starch actually was escaping digestion and going straight into the colon. So right from then, I've been a firm believer that the starch we eat in India is an important fraction of the energy that our bugs use in the colon and the small intestine. So I think that in that sense, energy is not a consideration to think of when we think of, can we make these bugs work better? We've got to think harder about this. The second is, these bugs don't only use the urea, they can also use preformed amino acids that you're eating. So there's no net gain to you. They're not taking urea and reconverting it to amino acids. They're just taking the amino acids you eat, using it, and passing it on to you. There's no net gain. We have to measure these things as well. But importantly, I still think, as a physiologist, that adaptation in the human being is an extremely important thing. And the urea pool, although it's hard to think, how does a bunch of bacteria in your small intestine know what your urea pool size is? Well, it could be just that the amount of urea or the molarity of the urea in the colon and the small intestine goes down, and therefore they detect that. I don't know. But it is worthwhile for us to still consider that in those populations who eat a lot of starchy foods because of poverty, this is an important issue to consider. So this is just my summary slide, and I want to say that the intestinal contribution is there. We always wondered about it. We knew it was there because of the double-labeled urea experiments, but we now know it's about 20%. It has implications for amino acid security in this country, but here's the problem. I still don't know how to make them jump through hoops and do what we want them to do. It's about 20%. It's fixed. Are there different bacteria that could do different things? By giving probiotics, are you going to change this relationship? I still don't know. But I do know that it exists. Thank you.
Thank you, Dr. Anurag Kurpad. One question from because of want of time. Any question? Yeah.
Work is very good, but you know that some lactic acid bacteria, I think it was not discussed in today's deliberations. They produce the biogenic amine. And this is a very important criteria which was not included in the government of DBT's guidelines also. I think I have given my personal suggestions to DBT because biogenic amines is a precursor of the cancer. And that is very important when we screen the characters of the probiotic characters of a particular lactic acid bacterium or the bacteria. So have you done this work and all?
No. I'm very clear that what I've done is adapt a breath test for use to quantify whether the bacteria in the gut offer more than what we think they offer in the colon alone through butyrates and all the other things they do. I think they definitely offer amino acids. The next thing I'm chasing is B12, by the way. But beyond that, I've not looked at all this. But I agree with you. There are several considerations to take forward.
Is it one of the criteria?
We thank Dr. Kurpad for his excellent presentation, and with this we close the session, and we thank all the three speakers for having done an excellent job.
May I request Dr. Dinesh Kini to please hand over the memento to Dr. Mohandas. Is he around? He has left? No,
is Dr. Mohandas around?
Okay. And Dr. Kurpad. And Mr. Minoru Shinoda to please come up and give the Dr. Mohan actually one is heavy enough, sir. Please. And now for the last session of the day, the panel discussion towards the future. May I request Professor Mehra to please come on the dais and chair the session, as well as our panel moderator, Dr. Ramakrishna. A few words on Professor Mehra. Professor N.K. Mehra is Professor and Head Department of Transplant Immunology and Immunogenetics at All India Institute of Medical Sciences, New Delhi. He is a Fellow of Indian National Science Academy, Fellow of Indian Academy of Sciences, Fellow of Hungarian Academy of Sciences, and Fellow of International Medical Science Academy. He has received over 8 awards and has over 425 publications in peer-reviewed journals. Sir, shall I call the panel? So, may I call the rest of the panelists up here? Dr. Joel Dore, Professor Kiyoshi Takeda. If you all would please come on the dais. Dr. Hemant Goshia, Dr. Sarat Gopalan, Dr. Dinesh Kini, Dr. S.K. Mittal, Dr. Hemant, okay. So you could continue. Actually, most of our panelists have been introduced except for Dr. Gopalan and Dr. Mittal. So if you could just introduce.
Well, they are both very well known. Sharat Gopalan, of course, is the senior consultant pediatric gastroenterology in ESI Hospital and Indraprastha Hospital in Delhi. His mic is not working. And the deputy director of the Nutrition Foundation of India. Santosh Mittal, of course, is a friend of mine for 40 years. He has been from AIMS and a very famous pediatrician there. I would like to welcome you to this last session, which is the panel discussion there. I think I have been very fascinated with the theme of this year's symposium. The theme states probiotics in the prevention of lifestyle disorders. And I'm reminded of this hygiene hypothesis, which has been put forward by Jean-François Bach in France, which states that countries or regions where the infections are very, very high, there, of course, the autoimmune diseases and cancer rates are lower. Countries in which the autoimmunity is very high, the infections are lower. So there is a north and south divide. As you see, there are the Scandinavian countries where the autoimmune disease, particularly type 1 diabetes, being extremely high. They're already seeing children at 3 to 5 years of age. And Dr. Mohan said that he's also seeing children at 5 to 7 years of age with not just type 1 diabetes, but also type 2 diabetes. And that's remarkable. So we are in India, the Indian subcontinent, where the infection rates are now dropping down and the autoimmune, the lifestyle diseases are increasing. And who knows that in years to come by maybe the predictions are by the year 2025, India will become the world's capital of diabetes. And I think if we are talking about the future, of course, of probiotic research throws a lot of challenges for us. A lot of challenges in the light of the information that we have gained. Very nice studies done by Dr. Takeda's group showing the very important role of probiotics in immunity. But we don't know yet the specific cell types in the whole immune system over there, which are affected the most. The role of host over here, the host interaction. We had that very nice study by the French group on the gene expression there. We don't know whether probiotics at a younger age are helpful or at the older age. So here it throws again the very important role of immunosenescence that sets in at the older age. Beyond 60 years of age, we already know that the cancer rates and the CVD and the autoimmune diseases will go up, and that is because of the effect that the second signal in the immune system is going a little down. So I think there are questions over there whether the probiotics, the beneficial role of probiotics will be more if you start them early on, or their role at the older age. I think the time at our disposal is very, very small, and Dr. Krishnan, of course, in his role of a moderator, has already set up a question bank over here for all the panelists, and I would ask him to sort of throw these to the panelists here. Meanwhile, we would ask you to write down your own queries and all, then send it over here. We'll give it to Ken.
Dr. Mehra. Yeah, we have a limited time at our disposal because we are running late. A few days ago, I circulated a list of possible questions to the panelists, but now I'm warning them that I'm going to ad-lib it from here, and we're going to change the questions because it's clear that there are certain things that cropped up in yesterday's and today's discussion that people are very interested in. If you look at your program, you'll see that this panel discussion is titled Towards the Future. So we're not actually looking backward, we're going to look forward. I'll start with a little, some of the things which cropped up repeatedly. So, Dr. Dore, I'm going to ask you, do you think that curd or dahi, as consumed normally, is a probiotic?
Okay, so I'm the microbiota expert. I would say not the probiotic expert, but yet I can address this question. Based on the definition WHO is providing for probiotics, it's not one microorganism, it's a community. So for me, it's difficult to associate the term probiotic to a community of organisms. And so hence, I would say that you need to know which is the active strain, and then you can call a strain a probiotic if you have the bioactivity demonstrated.
I'm not sure that completely answers the audience's question. So maybe I'll ask one of the clinicians here, Dr. Mittal, to comment on, do you think dahi is probiotic?
Dahi being a probiotic,
since you raised the question, I'm turning it back to you.
This dahi being a probiotic or not is a little, the experimentally now they say that probiotic organisms in dahi are not very resistant to the acid and the bile. So theoretically they don't fit into this. But let's not forget that the whole science of probiotics arose from the concept of better health in those people who were consuming fermented foods. So whatever may be the modern science saying today, there is no doubt that these fermented foods do give health benefits. Whether they are strictly probiotic or not is a different matter.
Okay, I have here a question from the audience. And this says in India, dahi is more, we're still sticking on this. Dahi is more commonly and widely used. What is the pattern of live bacteria found in dahi? And is that different from Yakult probiotic milk? This sounds like something from Yakult. Yes, so I think Sharath wants to answer this.
Dr. Ramakrishnan, I'd just like to draw your attention to a presentation at a previous probiotic symposium by Dr. A.K. Srivastava from the National Dairy Research Institute. And the presentation was all about dahi is not a probiotic. That was the title of the presentation. One of the arguments was that dahi contains a mixture of lactobacilli, and the composition of dahi is very variable from region to region, and from even in the same region from place to place. Although it has various lactobacilli, the composition, the amount of each of the lactobacilli is suboptimal for it to be termed and defined as a probiotic. So this was the argument put forth. This was one of the main arguments.
So the point here is whether any case-controlled studies have been done. Of course, you're right that dahi varies from one part of India to the other. From North India, go to South India and all that. The way they make the dahi. But as any case-controlled study.
The only study we know that, which was presented by one of our colleagues today, which was done in Delhi by K.N. Agarwal Group, between dahi and the probiotic dahi. And they showed that dahi also had an advantage, though the probiotic dahi had more advantage.
Let me ask Dr. Koshia as a regulator, if somebody came to you in Gujarat and said, I want to market a probiotic dahi, what steps would you take to look at it?
I'm happy to permit them because, again, as a food, without any medicinal claim or any at all claim, even if you have a claim, if you have scientific data, then certainly under food category, we are happy to license that and happy to allow.
Would you label it as a probiotic if it had no health claim?
Again, it has a nutritional value. Yes, as a food, we permit that, yeah.
Okay. I think, Dr. Ramakrishna, this is very important. Dahi, let's not look at only for probiotic. It has a very good nutritional component.
No, that was not the question. Dahi can be marketed as dahi, but can it be marketed as a probiotic dahi without, if there is no health claim? That was my question. If the answer is yes, that's fine, that's informative. Yes,
if I may, just a short comment. I mean, one of the first elements of the characterization of the probiotic that was proposed by your expert was that you need to be able to describe the strain very precisely. And I think that from what we heard, I mean, it's more a traditional preparation and it will be different from one preparation to the next.
Mm-hmm.
So you will not be able to define precisely what it contains. So
I think Dr. Shashikaran addressed quite a bit of this in terms of, when a health claim has to be validated, to be labeled on the label as a health claim. For instance, promoting gut health is kind of nebulous. It doesn't tell us what this could be.
What you could consider is it's probably a good source to look for candidate probiotics. Really.
So another question that cropped up, and again, Dr. Dore, I'm going to ask you to address this, is whether anything outside the lactobacilli, the bifidobacteria, and the others that we heard of, any other microorganisms which are there normally in the gut microbiota, could they be examined for probiotic properties?
So there's no reason why they should not, and they could not. We have examples in the literature of commensal gut bacteria that have very interesting bioactivity. For example, immune modulation can be driven very markedly by some of the commensal gut species. Now the difficulty might be whether it's feasible to provide those into food preparations. And many of them will not be considered as generally regarded as safe with this long history of usage in food preparations, as was also mentioned as one of the key criteria for probiotics. So they have to go through the validation process, basically. Also, I should mention that the dominant gut commensals are, for many of them, strict anaerobes, so they require culture conditions that are a bit more drastic than most of the lactobacilli or bifidobacteria that are used in food industry.
Let me address the question to Dr. Takeda here. This is, what do you think that probiotics have any role in augmenting the efficacy of immunization, childhood immunization?
So I assume that probiotics actually maintain the essentially required for the maintenance of the gut homeostasis rather than the immune responses. So by maintaining the gut homeostasis, probiotics can be useful as the for the health maintenance, or even for it's good for the treatment of several inflammatory diseases, I guess.
Mm-hmm.
So in this case, probiotics can mainly act on the, I guess, innate immune myeloid cells. So I think the understanding how these probiotics can act on the innate immune myeloid cells or the even epithelial cells, understanding these mechanisms is very important for the usage of the probiotics in the future.
I am specifically thinking of orally administered vaccines, like, for instance, poliovirus, which we know that in our milieu, we have to give many more doses to induce immunity. do you think that probiotics would have a role there?
Oh, actually, this is a tough question for me.
Can I raise the question? You know, currently there is a lot of interest in looking at the primary immunodeficiency states over there. Has any study been done anywhere to look at the beneficial or immunopotentiator role of probiotics in them?
So actually, I think that the probiotics can act on the vaccination against viruses rather than, I guess, these probiotics can enhance the status of the gut homeostasis or the enhancement of immune responses. These indirect effects can be useful for the prevention of infectious diseases, I guess.
A question to Dr. Mittal. What is the youngest age at which you can give these probiotics to infants?
There is actually no young age. You know that one of the most established use by Cochrane Review, etc., is the role of probiotics in prevention of necrotizing enterocolitis in preterm babies. So those are at birth, and those are even, in fact, before their expected time of birth. So these are 30 weekers, 28 weekers babies. So there is no really youngest age, any age they can give. In fact, we know that now mothers being given probiotics to possibly prevent infection in the newborn. So that
And
is
there would be no safety concerns in these.
there are safety concerns in premature babies. They have been raised, but as far as I know, till now there has been only one documented case of a translocation of the bacteria from the gut into the causing a septicemia. So by and large, I think the concerns still remain, but it has largely been proven to be safe.
Sure. You're also a pediatric gastroenterologist. You use probiotics in your practice?
I have used probiotics in practice, but again, for different indications. Probiotics, as a pediatric gastroenterologist, we are quite familiar about probiotics being used in diarrheal disease. And there's a lot of published information worldwide established, and emerging data from this country also, that probiotics do help in diarrheal disease. But what is of special interest to me is another indication, the exact opposite of diarrhea, namely constipation, for which one specific probiotic strain has been shown to be useful from published literature, that is L. casei shirota. And in fact, this would be quite interesting to see, to substantiate whether this particular probiotic strain, based on published literature abroad, has the same effect in this population in South Asia, for example. And it could be used as an adjunct to regular allopathic treatment, especially with parental concerns. We face it, both Dr. Mittal and I. Mothers who have been having their children, because in fact, one of our colleagues, Dr. Lalit Baradia, I think he's in the audience here, he presented a few days ago, last week in Delhi, a presentation on constipation, where he had clearly mentioned the data that the treatment of constipation is anywhere between 6 months to 5 years. So it can be quite frustrating for parents. And they are very concerned about the long-term side effects of these medications. So if something is available which may help in making them move off their allopathic treatment earlier, this is something which could be explored.
There are, so there are a couple of questions from the audience which relate to probiotic use and diarrhea. So Dr. Mittal, I hope you can take these. The first one says, does probiotics administered alone without antibiotics control diarrhea?
We know that antibiotics are not required in acute diarrhea. So the question of asking this, that whether probiotics will work without antibiotic, I think is not very relevant. In any case, I don't think the combining antibiotic with probiotic is itself a very rational practice. Whether probiotic per se will have an effect on the duration of diarrhea, yes, at least two strains of lactobacilli. The Lactobacillus GG, that is rhamnosus, has been shown to reduce the viral diarrhea duration by about 18 to 24 hours in a large number of studies which have come from Scandinavian countries and US. So that can possibly be taken off. Saccharomyces boulardii has been tried in cases of antibiotic colitis, which has been useful. But in general, large number of diarrhea children without etiological, yes, now there are some studies, the Cochrane review is pointing that there is some benefit in terms of duration of diarrhea, but whether that benefit is really going to make, is going to be clinically significant is something which we need to look at.
So the second question also on these lines is interaction of probiotic with antibiotic therapy in diarrheal disease. What should be the gap between the two? Firstly, you said you don't need antibiotics, so that straight away takes it off.
Yeah, I think if you don't, I think the most important way to prevent antibiotic diarrhea is to prevent antibiotics. Don't give antibiotics, you will not get that.
Dr. Shinjini at the back has a question.
No, I want to actually say something as a follow-up to what Dr. Mittal has said. You know, we've been discussing use of probiotics in diarrhea. Year after year, we say there is emerging data, there is ample data. I think it's very clear the data that we have has a lot of heterogeneity. Data is not from our settings. And I think whatever data we have is limited, particularly Saccharomyces boulardii. It's used rampantly without any evidence. And I think we really need to take a call there. I don't think we can stand on a forum and say that there is enough data for Saccharomyces boulardii or any other probiotic. Rotavirus diarrhea, yes, but again, not from our settings. So, you know, I think what we are talking about the future. I mean, if that's what the panel is meant for, we have to actually take a call on what are the future questions we need to answer, and not dwell on the data that is already available.
Shinjini, if I was asked a question about what is the future of probiotics in diarrhea, I would have probably answered that. But presently, whatever is available, I answered according to. And I will definitely supplement that there is no scientific body in the world which is routinely recommending use of probiotics in acute diarrhea. Despite that, the use of probiotic is very rampant in everywhere it is there, and that is something which we cannot control. I wonder how was in 95 these Sporolac came in as a probiotic acute diarrhea. It started getting used. How was it approved by the drug controller? At that time, there was hardly any evidence of probiotics being for use for diarrhea.
Sir, 1 minute. Just in continuation of what we don't use antibiotics, induce diarrhea, and then add a probiotic. But some other pediatrician has given antibiotic and the child is next day with you, what will you do?
Sir, in large majority, please stop diarrhea, please stop antibiotic, and everything will be all right. Most of them will settle down by just stopping antibiotics.
Yeah. So, okay. So I have two more questions here from the audience. So one, maybe I'll address this to Dr. Dore. I don't know that you have the information. The strain Lactobacillus casei shirota, does it have any influence on Helicobacter pylori in the stomach and in the gut? Would you know?
No, I have no idea. I'm sorry. I don't know.
Anybody in the panel care to take this question? No. Sorry, no takers. Okay. So the second question, and I'm not sure who I should address this to. This is high fat intake for ketogenesis. Yeah. Role of probiotic prescription to mitigate negative effects of high fat intake. I think Sharad looks the most hopeful here. So you want to take that on?
With regard to high fat intake, no idea.
Okay. I'm sorry, Dr. Kurpad is not here on the panel.
There was a session on the role of probiotics in disease states, and we heard from cancer and from diabetes point of view. Is there any evidence now, or do we need to generate evidence what combinations of the probiotics would be beneficial for a particular disease state? Or is it at the moment a hit and trial, sort of give this and may, it may
No, Dr. Takeda, maybe.
benefit or not?
No?
I'm sorry, I have no idea.
I think that there's some literature on the use of prebiotics in management of low-grade inflammation in type 2 diabetes. And considering the concept is that of a diet change inducing dysbiosis, inducing alteration of the gut barrier, inducing inflammation, then if you tackle diet and dysbiosis, you may actually be working with the very early events of the succession, so it might be very relevant actually to pursue that line. And probiotics might have their role to play in this domain also.
Dr. Mehra, regarding combinations of probiotics, for specific therapeutic indications, there's published data on a particular probiotic combination being useful in a disease state, in pouchitis, ulcerative colitis, very well documented literature.
So I think we are nearly running out of time. I have a question for Dr. Dore. I mean, you've done these multi-country European studies, and you're very conversant with the gut microbiota of Europeans. Is that right? And you said that you have information on enterotypes in over 1,000 individuals. Yeah. So do you know how many of them were actually taking regularly probiotic foods?
So we had actually in the meta-hit study questionnaires for food intake for both our obese and control cohort and the IBD and control cohorts. And in a few cases we had reported intake of probiotics. So it's only a small fraction of our populations that were regularly taking up the probiotics. And in one case, we were actually able to predict, because we could see a complete genome of a probiotic strain that was observed in the metagenomic information that we could obtain from that person.
Did it influence the enterotype, regular probiotic intake?
So we have no idea about the
haven't
influence
done
on
that yet.
enterotypes. No, it would take a specific
Can I just
trial.
raise one more point? You know, as we know that the cancer rates tend to go up as the age advances, and one of the factors that has been associated with it, that as the age advances, the immune system tends to senescence. I don't know whether probiotics could actually help in terms of improving the immune system and therefore the cancer rates. Have any experimental studies in progress in your center, Dr. Takeda?
In terms of this, now the mouse models of the immune systems, as far as I know, there is no such a kind of the models at this moment. So actually, we should establish this kind of models to reveal how probiotics can influence the immune systems more precisely, I guess.
So I'm just going to read out this one last question and then we have to wind up. This is from Dr. Prabhudas, who's a GI surgeon from Apollo, Chennai. As a bariatric surgeon, I'm interested in knowing if probiotics should be administered after gastric bypass surgery. If yes, how long? Dr. Dore.
Well, we've worked a little bit on gastric bypass surgery to looking at the impact on the microbiota. We do see an impact on the microbiota. We do see amelioration of the overall context, as was mentioned this morning. And I don't really see where, in terms of rationale, I would see a need to suggest application of probiotics. So for the moment, as far as I am concerned, I don't see what the rationale would be to specifically apply the probiotics in this context.
Okay, so I think, Mr. Chairman, would you like to conclude? Yeah.
Thank you very much for really wonderful job. And I think it is very clear
that there are more questions than answers. You could see that there are several questions of which maybe the answers are not there. The more we meet, the more we have interactive sessions like this is going to really be very helpful for us to understand exactly the role of the probiotics. One of the areas that we have really not talked about is actually the role of the host factors, the population-based differences over there, whether the gene expression studies in one ethnic group would be similar to that of the other, and whether use of the various strains of probiotics would be. So I think there are a number of questions over there that still remain unanswered. There are not many case control studies that have been done to prove the various points. So I think at that point of view, the future has more challenges and future has more opportunities as well. So I think with that, we would like to wind up this panel discussion session, and I would like to thank all the panelists over here, more so the moderator, Dr. Rama.
Thank you very much to the panel, and maybe have a round of applause for the panel, please. Thank you all. So, I'd like to call here.
May I request Dr. May I request Dr. Mehra to please present the memento to two of our panelists who have not come on the dais before, Dr. Sarath Gopalan and Dr. Mittal. And last but not the least, may I request Mr. Marcel Bato to please come on the dais to present the memento to Dr. Mehra. And before finally closing with the vote of thanks, I'd like to request the organizing committee members to come on the dais, please.
So before we do that, can I request Dr. Neerja Hajela to come up on stage and give a memento to our MC, Dr. Deepika Sur.
So on behalf of the Yakult India Microbiota and Probiotic Science Foundation, we would like to thank Dr. Deepika Sur for being an outstanding master of ceremony. And may I request Dr. G. Balakrishna to please hand over the memento to her.
Picture. But then the organizing committee members.
No, vote of thanks.
Then vote of thanks by Dr. Ramakrishna.
So it's my pleasure to give this vote of thanks. So firstly, we will thank Dr. Neerja for having done this thing so wonderfully. With Dr. Dinesh Kini for having graciously agreed to be a co-host for this. He's not here. Dr. Ganguly, who is the president, who is kind of masterminded this in absentia, Dr. Balkrishna and Dr. Shashikaran, who are both vice presidents of the foundation, and to all the members of the organizing committee of the foundation. To everybody who's been here to support, and Neja hasn't actually given me a list of who to thank. Yes, of course. and to all the participants for having been here and actually interacted very well. So if Neja will come in.
So yes, I need to thank, while I get all the applause, there's a lot which comes to me in terms of support. The tremendous support that I get from the governing body of the Yakult India Microbiota and Probiotic Science Foundation, from my senior colleagues both in the parent companies Yakult Honsha, Group Denon, and my managing director and Mr. Tomoyuki Iwama at Yakult Denon India. Our senior science executive, Priyanka Saluja, who does a lot of work behind the scene, the event agency, Planet, especially Pooja, who had to go back because of a mishap, but Priyanka, Simi, Vikas, and Afsal, they have done an extremely amazing job. And of course, Sheraton Hotel and Nitin Maria especially, who's been around for 24/7. And of course, all our esteemed chairpersons, speakers, and delegates, without whom this symposium would not have been possible. Thank you very much. Thank you.
Could we call the organizing committee members, our friends from Japan and also from France? Could you please come on the dais? They'll take a group photograph. Please, sir. Would you sit or stand in front? That would be nice. There aren't too many people. So you could stand in front. Yeah, that would be better.
National